Bernie Sanders posts out, a new study confirms that Medicare for All would save 114,000 lives every year and reduce overall healthcare spending by more than $1 trillion annually. Do not tell me we cannot afford Medicare for All. What we cannot afford is a broken healthcare system based on greed. And so they're going to transfer this to a new system where there won't be any greed that takes place in that system. All right. And now
we should have done that a long time ago.
Yeah. I mean, I don't know why they didn't think about it.
Why is there not like a law against greed?
We could look into it.
Yeah.
I'm surprised he hasn't introduced that, actually.
I feel like it just needs to be like one sentence. Like
just no greed. Just can't have greed.
Yeah. He doesn't just greed with the strike through.
I want to go to this More Perfect Union post because we're going to do a little bit of their article before we get into some details. A new study shows Medicare for All would save over 114,000 lives and over $1 trillion per year. The new research out of Yale shows that reductions in administrative overhead, lower pharmaceutical prices, less fraudulent billing, and fewer emergency care trips would lead to a massive savings nationwide. More accessible care would also lead to numerous lives saved. Okay. That first off, this Yale study, the one that Bernie Sanders said confirmed, and this person says shows, just so you know, it has not been peer reviewed and totally based on models. Literally doesn't confirm anything at all unless it's confirming your own biases towards something. It confirms that. But that's basically what the study's going to say.
Also, who's running the study? Academics tend to be very left-leaning folks.
Yeah, for sure.
That if you polled all of them, I bet almost all of them would say that they're for Medicare for All prior to running the study.
Yeah, and you can actually tell by the assumptions that they make in the study that they're very left-leaning and that they want this to happen. They make all of the assumptions that they make are very rosy assumptions without bringing in any downside unintended consequences as a result of these policies. So there's been, I think I'm just going to go to my notes on this, and I do apologize if you're watching on YouTube. Just get over it. Okay, get over yourself. All right, I didn't make it pretty or anything. I'm literally opening my notes for the show, and you'll see that they're my notes because there's little things for me to remember throughout us talking about this. Okay, so why is this so much?
This is a special episode. This is inside the mind.
Special. This is hot off the presses. We haven't had time to make it look good for you folks. We just got to get this info out there just immediately. Okay, and so here are the notes. First off, why is this so different than what even Bernie Sanders and what the previous studies have shown? They used to say it would save us $600 billion, and now they're saying $1 trillion. It's going to save that. They've made some hilarious assumptions that we'll get to here in just a sec. Here's some of the numbers. Eliminate avoidable emergency or inpatient care. That's going to save $100 billion. So people are going to ERs. They're not going to need to go to those ERs. Okay. They're instead going to go to other primary care things that they're not doing right now, but also we're not going to count what that would cost. Pay hospitals and clinicians at Medicare rates. So this is where they really found all the savings in comparison to previous stuff. In this study, they have decided that basically everyone who works in the healthcare field is going to get paid what the Medicare rates are for everything, and everything's going to be fine and nothing is going to change whatsoever, except for that they're going to take less money for all the stuff that they do, and that's how we're going to save all this money.
Do people even know what that cost difference is?
So I know what the cost difference is. Yeah.
Yeah. So
you do too.
Yeah. So there's a Medicare base rate for a DRG. This is for inpatient stays, but also your APCs on the outpatient side. There's a Medicare base rate for that. Then you have modifiers and different things that can change the bill. However, a roundabout assumption of what commercial payers pay versus what Medicare pays is 205%. Mm-hmm. So double.
Yeah.
Basically. So if
the numbers I saw were actually 250%.
Yeah, this is a round about assumption, but you can basically say double. And so if the Medicare base rate, let's say for a broken arm, is $1,000 to a hospital, That means United or Blue Cross Blue Shield, really it's your employer, facilitated through those payers, is going to pay $2,000 for that same procedure. Medicaid, on the other hand, pays about 60% of that Medicare base rate. So you're only, if you're on Medicaid, you get about $600 for that same procedure.
Mainly all these hospital corporations, they make their money from private insured individuals. Okay. Now they can make a little bit of money off the Medicare stuff for sure. They're probably losing money on Medicaid patients, which is why they hate taking them so much. But they're making a good portion of their money from private insured people.
The bulk of every hospital is private insurance.
We'll get to more on that here in just a sec. They're going to do international reference pricing for drugs. So this is what those drug companies are charging these other foreign reference countries that we're going to pick. And they've estimated that all of our drug pricing will be cut in half by just them only being allowed to charge what they charge to these other countries.
Yeah, and drug companies will just
going to do that. Nothing's going to change. It's going to be awesome. They're going to reduce administration costs to 2.3%, which is roughly what Medicare's admin costs are. I'll get into it. Before we get into nitty-gritty details on stuff, they're saying that's going to save $286 billion. They're going to reduce fraud, they say, by 8%. I think they mean like a nominal 8% or whatever, but they're saying that's going to save $285 billion.
Most of the fraud is in Medicare and Medicaid.
It's really funny. They think that we're going to switch it all over to Medicare, and even though they can't fix the fraud in Medicare right now, they're going to put it all into Medicare, and then they're going to reduce a bunch of fraud, and they're also going to reduce all of the admin costs, even though they're also going to have the most efficient fraud prevention program that we've ever had. So
you really don't see fraud against commercial payers.
Well, I mean, they have a very big incentive to find it. Okay. They're going to cover the uncompensated care. So that's going to cost, they're saying $51 billion, which they have fairly decent numbers on that because hospitals report what their uncompensated care is. So basically care that they're providing for free to people, which they then roll those costs into what they charge everyone else, or they write that off against what they're going to owe in taxes, stuff like that. Then they say something's going to cost money. Greater use by uninsured and underinsured people. That's going to cost $200 billion more.
Which the Affordable Care Act fixed, but the problem still exists.
But there's still just a couple people out there, I think. And then they're going to cover dental on this, and that's going to cost an extra $54 billion over the current. This is going to save 114,000 lives. It's going to save $1 trillion every single year. We'll go into a couple things on this. Don't worry, I've got notes on each one of these little things that we're talking about. So saving 114,000 lives. You might ask, well, how did they get to that number? This is the kind of thing that people are going to use when you're watching on social media, or you're reading people's posts on social media. You're just putting profits over people. Look at all these people. These are the people that are dying. Now, if you don't do this, then you're responsible for the deaths of 114,000 people every year.
Elon. If
you don't do this plan. Anyone who doesn't want Medicare for all is essentially helping murder 114,000 people. Okay? That's what we're looking at right now. So the uninsured number, they take this, they look at the uninsured people, underinsured people, what's the greater risk of them dying because they can't afford care, stuff like that. And that's based on an old study, the uninsured number is. That study assumed a 1.4 relative risk to insured patients. So like a 40% higher risk, doesn't mean 40% more people dying or whatever, but a 40% higher risk. That study presented that number with a 95% confidence interval, and they said that number was somewhere between 1.06 and 1.84. So what they said was they're 95% confident that it's the same or 80% higher. We're not sure which one. And then so they settled on 1.4. Okay. That's the underinsured number. This is where they come up with these numbers of people that they're going to save. Is totally made up. It's literally made up. They say in the study it's made up. They assume this number, it's a little bit lower than the 1.40. It's like 1.2 or something like that. And they go through all these things that they did to assume that number based off of the other assumed number. Okay. And they're all assumed, by the way, because these are all derived from models, not real world examples. And many of them are from like Obamacare studies that were done about uninsured, underinsured people and all that. And they've never taken then real population samples and said, yes, it turns out those numbers were correct and there is a 40%. This is all based on models from that time.
Models based on models.
Yes.
On models.
And then the rest of it.
And they came up with that. They all sat around and they were like, how many lives will this save? You know, 100,000. Well, that sounds too believable.
No.
You know, somebody was like, what about 115? You know, just increase it a little bit.
No, that's too many.
That's too many.
No, that's too many.
And then somebody said 113,000 lives. And they're like, well, I don't like prime numbers. And so somebody was like, what about 114? And they all agreed.
They agreed that was the right
unanimous
answer.
Consent.
Yeah.
114,000.
Well, it's not just 114,000. The actual, I'm trying to find what the actual number is. It was like 114,117 or something like that, to even make it even more exact. Yeah. Like they know exactly how many it's going to save.
Or kill if you don't support.
And by the way, as we go through the other stuff, I want you to also know that whole lives saved number of 114,000 they have not then offset that by potential future lives that are lost to higher wait times, substandard care, reduced quality of care, or any kind of reduction in new life-saving medications and treatments. They're not going to like deduct any from the 114,000 because nothing bad is going to those things I just said are not going to happen. And so there's no reason to take those off of the 114,000 lives that are going to be saved at all. Oh, I did put in print. I told you these are my notes. It says personal example right there. My personal example on this is I know someone who works in research. Okay. Works in research. I'm going to say for cancer. That's fine. I know someone who works in cancer research. And for a while, this someone was telling me about this new cool thing that they were working on over the course of a couple of years. Like, hey, this is pretty cool. You know, we're looking at this and telling me the numbers on it. It seems to really be working, you know, seeing really good results from this. And once they got that all packaged up and they got approval on it, they sent it through Medicare. And they said, let me tell you this first. They did all the numbers and they figured, because this person's on the financial side of this whole thing. So she was a part of working on numbers on stuff. And by the way, one of the categories is not like profits for the big guy or whatever. Like they're just looking at what does it cost us to do this? And they found out that like for this treatment right here is $155,000, something like that, for us to do like a round of this treatment. And so they send all this to Medicare. And Medicare comes back with, we'll pay you $50,000 to do that. So what do you think they did? They took the $100,000 hit for each round, right? That's what they did?
They shelved it.
They shelved it. They got rid of it. That's it. Done. They can't just offer it to insured patients because you got to offer it to everyone. And they couldn't take the hit because a larger portion of the patients were going to be people that were on Medicare or Medicaid. And so they couldn't just release this thing. Here, we've released this new thing and we're going to lose money every time we do it. Isn't that awesome? Because you know also, then who's going to use the Medicare rate to decide what they're going to pay for it? The private insurers are going to use the Medicare rate. And guess what?
It'll be about double. So
it's going to be about double or a little bit more. And so even based off the Medicare rate, they couldn't even get to a number that would make that person profitable when they came through. So they're going to lose a ton of money on the Medicare people and even probably lose money on the private insurance people. And so guess what? Gone.
All that work, all the research.
Mm-hmm. Years. She was telling me about this for years. When we would IM on MSN Messenger, this person I knew.
Yeah.
Back then.
Trans woman.
What?
She's a tranny. You're talking to a dude. And
all right.
Here's the thing. That stuff doesn't get reported on.
Yeah.
And so that happens way more often than you think. It would be interesting if we could get data from like Vanderbilt and the Mayo Clinic and some other places that do a lot of trials, clinical trials, how many drugs are introduced, what their efficacy rate is, what their projections are, how often those make it to market versus not, what are the potential lives that could have been saved from those treatments or drugs or different procedures that were all, now you killed those people.
Yeah.
You killed them.
You basically, I mean, if us not supporting Medicare for all killed those 114,000 people, then they killed those people too. You know, that's just,
I think it was
except for there's a little bit more.
It was 126,000 people.
It's about 135,000 from what I could tell.
Yeah, exactly.
Okay, let's see. I'm still going through my notes here.
Hang on, let me put it through the model. Oh yeah, 136,482 people.
That's crazy.
That shelved treatment would have saved.
Mm-hmm. Let's see. Saves $1 trillion. We're going to get to a little bit more of this here in a minute, but it's higher than the previous estimate. I already said that because they decided to assume everyone would work for Medicare rates and nothing at all would change. Okay, so we're going to get to that. That's the craziest part of this whole thing. So they're going to eliminate avoidable emergency and inpatient care, and that's going to save $100 billion. Okay, so that's assuming that people will use less emergency care when they have free. By the way, anytime I say free, we're talking like at the point of service, not actually free because someone is paying for it. Someone's getting paid, someone's paying for it. It's not actually free. Okay, just for any other times we use free during this. It assumes people will use less emergency care when they have free access to primary care. It leaves out that there are people who would use emergency care now if it weren't so expensive. So by the way, it's saying, well, these people using emergency care, a bunch of them are going to go primary care and they're not going to be going to the ER. And then they don't then come back and say, but there's a lot of people who something happens. They're like, I should go to the ER. And they're like, no, that's too expensive. I'm just going to stay home. It's also assuming those people aren't now going to come to the ER. So it's all like positive, rosy projections on all this stuff. All right. It also assumes the population that's using the emergency centers as like a walk-in clinic, basically, are the kind of people that would then just, instead, they're going to go ahead and schedule their yearly or every 6 months with their primary care and just really keep track of their health. A lot of them are still just going to wait and just go to the ER when something's going on because it's right there and you can just go. Yeah. And, you know, whatever time of day it is, and you just go in there. Okay.
And you have to be seen.
Yes.
If you go into the ER.
And by the way, an Oregon study found that people getting on Medicaid actually increased ER use. There were, in fact, a lot of people that weren't even going to the ER. And people getting more government help with their health care actually ended up increasing the use of the emergency services, not decreasing.
Well, that saved more lives, though.
There you go. Saving those people. Oh, also the $100 billion figure is from a 2017 study, and all they did was adjust the 2017 study for inflation. There's also a lot less uninsured people in the population relative to 2017, but they didn't adjust that. They just took the number from that study and added inflation to it and said, this is how much it would save. Okay. And so there you go.
Seems like the elite level academics.
That's very good stuff. Very good stuff. I'm excited to see the peers review this one, and then we will finally know with 100% certainty that Medicare for All will work after these people come and look at it, and then it's good to go. This is my favorite one. This is great. They're going to save $300 billion a year because they're just going to pay hospitals, clinicians, anyone who is getting private insurance right now, instead is just going to take whatever the Medicare rate is for everything, and everything is going to be fine after that. They're going to take...
Oh, and by the way, they can just set Medicare rates.
Yeah. They're just going to set the rate. Everyone's going to work for it. There's not going to be any changes in the quality of care, wait times, the ability to get new people to come in to the healthcare fields, nothing like that. There's not going to be different facilities that need to close, that can't afford to operate just on Medicare reimbursement rates. Like, by the way, even someone like HCA, who owns a ton of hospitals and then tons of other healthcare facilities all around the country, in the world, actually. Are they the biggest hospital owning corporation, like as far as
by number of dollars? Yes.
Okay.
Not number of hospitals or patients.
If you took what their net income, what net profit was last year, and then you just assumed that all of what came in from private insurers, which is about half of their money actually, came in through private insurers, they would have actually, instead of profiting $6 billion this year, they would have lost about $15 billion this year.
Yeah, they're willing to do that, I'm sure.
They'll just take that one. Well, of course, they are paying their CEOs $16 billion. And so they, no, like anyone, when you look at these, they're like, well, if they just do executive compensation, dude, they're not paying $16 billion in executive compensation.
Right.
They'll look at like a negative 15 and be like, well, they just paid their CEO less. Like, okay, so they're negative 14 billion, 970 million. Not or for HCA, 995 million, something like that. Great. That's awesome. Now they fixed it. Now they can stay open forever. Now that they did that. A company like CHS would have to either go bankrupt, or they'd have to get a bailout, or they'd have to get some kind of extra special subsidy from the government to stay in business. And that number is not accounted for in this. There are many, many hospital systems around the United States that literally could not operate on just Medicare pricing.
Most of them are struggling to operate right now.
Yes, they are.
Most hospitals are actually, they already operate at negative profit margins.
It's like a lot of them, but there are so many that are already struggling that could not just take Medicare rates. They would have to get more subsidy from the government, bailouts, a new stream of money somehow from the government. And of course, that's not accounted for in the money that this is going to be saving everyone. It's just going to be what they're saving everyone, and not the fact that they're literally going to have to bail out like half the hospitals in America because they can't survive on just Medicare pricing. The international reference pricing for drugs. You worked with CHS there for a bit, or whatever for a bit. Like, wouldn't be good for them, right?
No, that wouldn't be good at all.
I assume they're against this.
They're not in a good position right now.
Yeah.
So,
well, it's because their administrative costs are too high. But
in fact, I think CHS has done like 2 or 3 spinoffs in the last decade, just because otherwise they would have gone bankrupt.
Yeah.
So Quorum Health, Tenet Healthcare, I think, is another spinoff. A couple spinoffs from CHS, because they used to have quite a few. CHS had like around 180 hospitals. I think they're down to like 70 or 80. So they've spun off over 100 hospitals just to survive as a company.
Well, all the money that is going to have to get put in those hospitals, just so you know, we're just not going to talk about that. That's another funding source that we're just not going to talk about. Okay. International reference pricing for drugs. All right. So that's great. Oh, this is what you're charging all of these foreign countries. Well, that's what you're going to charge here. A lot of people look at that and they would say, well, that makes sense. They're charging that to them and they're charging this to us, and that's unfair. And what a lot of people don't realize is that most of those other countries have price controls on the drugs, and they will go and they'll take it. Like that company will say, yeah, we'll sell it to you. That's fine. You can pay our cost on this or whatever. That's good. We're just going to get the extra elsewhere. And then they say that with each country, and then elsewhere ends up being America. That's where they end up getting the elsewhere.
We are, subsidizing the world when it comes to drugs.
So this would actually
for the most part,
bad for the world if they did that, because the thing that would actually happen, the first thing is they would stop selling drugs to some of these countries that they couldn't get higher prices from. And then they would try to get higher prices from a bunch of the other countries. And you might be hearing this and saying, well, that's good. They should be paying more for their drugs. Okay, well, whatever, that's fine. Then there's the other stuff that you're not paying attention to, which is that, what about new medications, new R&D? It takes a long time. Was it 10 years?
On average.
Billions of dollars.
A decade. In fact, I've talked to in talking with investors, you learn like what their thesis is, kind of what they typically, they invest in things they understand. Most investors, especially angel investors, stay away from biotech. And one of the main reasons, or biopharma, whatever you want to classify it as. But one of the main reasons is because your money will sit there forever, and you have no idea whether or not it's going to be cleared by the FDA. You have to get over a bunch of different regulatory hurdles, and then maybe you might have a pretty significant return. Now, there are a few people that are willing to take that risk, especially if they're in the space and they know it really well, because the return on the risk can be really healthy. You're talking 100,000x return. It can be. But most of them go to zero.
Now, the answer is, so there are people who put money into this. And let's be clear here, to take a nice Bernie phrase. These companies are making good margins. Like when they get one that hits, it hits. And it pays for R&D, and a bunch of these companies are making money. And that is true. What we're really losing here is whether or not it's going to be right for if investors are still going to want to put money into this, to let their money sit there when they can't get. You see, when you let your money sit for a while and like only 1 out of every 15 is like a big hit, you want that big return on that money. There's a ton of risk involved. And so there's a ton of risk. You want a big return while you're waiting on this. What happens if they take it down to like a normal return, like some other random thing? I don't know, investing in Stanley cups or something like that. We'll just do that. This is way safer. Yeah. Just make your safe money.
Put your money in a place where it could be more liquid.
Yeah. Just do that instead. And so there will be a loss of a bunch of these countries. They don't even cover like a lot of new medications that come out that we have a right to like a week after they come out. They don't even cover them. Like you look at the list of covered drugs in Canada and some of these other countries, it's not like just any medication that comes out, everyone there has got a right to it now and they're going to pay for it for you. No, there's a list of stuff that they cover and they're going to decide whether or not they're going to do it. It's not all just unicorns and rainbows everywhere around the world. By the way, it's pretty crazy. Like our generic drugs are 67% of the cost around the world. Our generic drugs are, so less than the cost around the world. So try and stick on generic drugs if you can. It's those new brand name patent protected drugs that come out that really get you.
If you see a TV ad, don't go for that one.
Nope, don't do the TV ad drugs. Those are the bad. But we're not saying to ban TV ads. I think that's ridiculous. They're going to reduce fraud, and that's going to save $285 billion. So they're going to, about 5% of the money that the nation spends on healthcare, they're going to take that they're saying that's fraud, and they're going to get rid of it. The way they came to this number was one example. Literally, Taiwan switched to this unified system, and they were able to root out a bunch of fraud in their system. And they said, well, Taiwan did that, and they rooted out like this much fraud in their system.
We'll just take that number.
And so we're going to use that number, and that's how much we'd be able to do. What they ignored was like Medicare is already on this big, giant, unified government database, and we're not doing that. I recommend they take this portion out and they just apply it to Medicare immediately. I think that'd be good. But they don't want to do that part. And so they're assuming, even though they can't root out the fraud in Medicare and Medicaid right now, that they're not only going to do that, but they're going to root out all the fraud that is currently happening with private insurers at the same time. And so that's what they're going to do. Now, let's see, did I skip over the administrative? Yeah, I did. Now, this is interesting because in order to root out all of that fraud, you're probably going to have a large administration that's going to be doing that. Maybe over time, you're going to put this all into some AI system that's going to run it all through there, make sure fraud's not happening, whatever. But you're going to have a lot of fraud checks, a lot of people looking into this stuff, more so than what they have right now by a large majority, and able to get, if you're going to be able to get to this $285 billion savings. At the same time, they're saying they're going to reduce all of the administrative costs. Okay? At the same time. So that's good. I've heard this argument.
We have AI now.
Yeah.
Nate.
I've heard this argument over and over again that Medicare's administrative costs is so much lower than private market and you would just save all this money. by switching to Medicare. And they use it as a percentage. They say Medicare's administrative costs is 2.3%. And compared to the private market, it's like 8% or 10% or whatever. First off, that's the government's fault for all those damn regulations, and I'm sure they're very sorry about that. Second, Medicare gets to use a ton of other people to do it. The private providers already doing a bunch of that burden before it gets to like Medicare. Here you go. And so they're doing a bunch of that beforehand. Also, Medicare farms this out to the IRS and all these other agencies and stuff that's divided between. And then there's also the other bigger picture, which is that they're showing it as a percentage. Okay. And so it's a percentage of the expenditures. Now, did I put down an example here? Yeah, I had to put that down. Your average Medicare patient is going to use a lot more healthcare than your average insurance patient. Okay. So this is important because if you have $100 administrative costs on $1,000 in usage, then that's a 10% administrative cost. If you have $100 administrative costs on a $5,000 bill, then that's a 2% administrative cost. The patients going through Medicare are using much more healthcare and having much bigger bills, not because they're paying out so much more per thing, but they're getting, dialysis every whatever.
These people are old.
Like yes, they're using much more healthcare.
Yeah.
And so the administrative cost is much lower because the bills tend to be there's a lot more money getting shelled out per patient. So anyhow, we got that. You were looking up something a second ago. Was that?
Yeah, I was seeing what the fraud was, Medicare versus commercial. There's no real good numbers on that. There is an estimate that 60 to 80 billion is lost annually on Medicare. But if you take total U.S. Insurance, it's roughly 3 to 10% of all spending is fraudulent, allegedly.
Did you say that's for Medicare or for?
That's all, including Medicare.
Okay.
The best estimates of Medicare is roughly 60 to 80 billion annually.
Okay.
But total fraud could be upwards of 300 billion. So that makes it seem like commercial is higher. That's possible.
And so what's great here is the government's going to get involved in the entire market. And from the number that you just gave, it sounds like finally what they're going to do, and they're great at doing this, they're going to get rid of all of the fraud. And so we won't have any fraud anymore because the government's going to be doing it.
They're great
at
reducing fraud.
Very, very good at doing that. They're going to cover uncompensated care. Okay, whatever. It was $51 billion is what that's going to cost.
Seems like a low estimate.
It seems pretty low. But yeah, now that would mean taxpayers are going to pay for the only free care currently being provided by hospitals, but it's still not even free. Of course, they're probably going to roll that into what they're charging other people, or they could just be knocking it off and owe less in taxes, in which case, sure, whatever. This is another really big one that they say is going to cost $200 billion. So they are saying that there is going to be greater use by uninsured and underinsured people. So those people who are underinsured, uninsured, they're going to use the healthcare system a lot more when they have this access to this free care. And they're saying it's going to cost $200 billion. This leaves out a pretty large group of people, by the way. And it's everyone who has insurance or some type of coverage or whatever, who's also going to use way more care because it doesn't cost them something every time they go there. They did not suspect that someone like, okay, well, it wouldn't actually change for me, but anyone who has insurance, who has something random pop up, that person is going to be more likely to use the healthcare system because it's going to be free at the point of care. It's only the people who are currently underinsured and uninsured, they're going to use more healthcare than before. So they come out to $200 billion on that, and that's still a smaller portion of the population that are in those two categories than all the rest of them. And so you probably assume it's going to be like double that amount, whatever.
But think about the lives being saved, Nate. You're not thinking about that.
That's the lives, yes. Mm-hmm. I forgot about the lives. And greater dental utilization. People are going to go to the dentist more often because it's going to be covered. And my only response to that is that all I can think of is what British people's teeth look like. And so I think that settles it, honestly. What? Really?
They have free healthcare.
No offense. I'm sorry. Okay, there could be a Brit. I'm sorry. That's offensive. No, you know what? Your teeth are offensive, honestly. So it's not me. It's you. Is the problem. No, it's fine. It's not. It's fine. You're a great person, I'm sure, whoever it is. I put here as a note at the end, give us one time in history that making the government the payer for a service made the service less expensive than what was taking place in the private market. Charlie, go ahead.
Never.
Are you sure?
Can't think of one.
Not one?
No, maybe cash for clunkers.
Everyone always goes to the mail, the postal service.
They suck at that.
Yeah. Or they'll go to whatever college
Police.
or some random stuff. And I'm like, no.
Firefighters.
No. They're like, yeah, the police are free. No, I don't mean less expensive. Like you have to hand over less money or you don't have to hand over any money at the time that you use them. I mean like the payment for the service, the people providing the service, like that entire thing got cheaper. The cost of doing this service or providing this product got cheaper in total payment for the service. I don't think that's ever happened before. I can't point to one single example of that ever happening. I would give you one. I'd say it. I'd be truthful about it. I don't think it's ever happened. But this assumes that this will be the greatest and most perfectly run government program that has ever happened, better than all of them, that there will be no unintended consequences. Imagine them selling you this thing, like Bernie is selling you this thing, and it's like, oh, it's going to be great. There's no unintended consequences, and it's going to be the greatest program that the government has ever gone on and endeavor on in the history of mankind ever. And I see no examples of that happening ever. In fact, I think
it's like Bernie selling money trees. Like,
yes.
Yes. Imagine he was a door-to-door salesman. It's like, look, you just plant this thing and plant it. How much?
Awesome.
How much does it cost? Well, it's $50,000, but over the next 10 years, it's gonna grow 100,000.
Yeah.
So you're gonna double your money in 10 years.
Yeah. Except for everyone else got money trees too, and that 100,000 is not going to be worth anything. But whatever, that's not going to be important. I would guess if they were to do this, I mean, think people who we have unique experience with healthcare. I'm close with someone who is involved in healthcare. I know them. Okay.
Well, we've been friends for a long time.
Yes, we have been friends for a long time. You've started business. You've got a business in healthcare. You've worked for some of these major corporations that we've talked about actually on this show, and people in the profession, and so we've and I know people on the financial side, on the number side, on the Excel spreadsheet side of this whole thing. The idea of the government coming in and trying to organize this, it's almost insane and maybe more insane than that whole idea that the Soviet Union was trying to manage the prices on like 25 million items or whatever it is. It's probably worse. It's way worse than that, actually, I would say. But it's along those lines is what you're talking about. It would be a complete disaster. It would not only not save 114,000 lives, it would cost. My assumption would be hundreds of thousands of lives. Yeah. The waiting list, the lines, the substandard care, the people not going into the medical profession that would have been going into the medical profession, the drugs not created that would have been created otherwise.
Hospitals and clinics that close down because it's no longer profitable to be in business.
And by the way, we didn't even get to. I didn't put
which
it on
creates
my notes.
longer lines at the places that are open.
I didn't put it in my notes. Last thing to talk about before we go. Who's going to pay for all this? How are you going to pay for this? Now, he says, don't tell me that we can't afford this. Well, of course, because it saves us money. But what people have to realize is that, okay, we pay too much for healthcare. That's true. Overall, in general, Let me rephrase
you can go
that.
as far to say, the system is broken.
Of course it is.
Yeah. Healthcare is entirely too expensive. And
it's more expensive than it otherwise would be if we actually had a free market. It's tough. Every time I say it's too expensive, I'm like, oh, saving my life isn't worth $2,000.
like your appendix bursting.
Like when my appendix burst and I was mad about the bill that I got. I wasn't worth $2,000. That's insane. What a ripoff.
Or even imagine if you had to pay the $24,000 out of pocket.
Yeah. Whole thing.
I should have just died.
Of course I would have. I could. Man, I wish I would have gotten a car instead for that amount other than saving my life. That would have been way more worth it if I would have gotten that car.
Yeah.
No, so it's tough to say it's too expensive because being alive is pretty valuable to me overall. But it's way more expensive than it should be if it were left up to an actual market to decide what the prices are. So, which
we had mostly prior to Medicare and Medicaid.
Yeah. They started finagling way early on, in fact, as we plan out some of these videos that we were talking about this morning, I think going back to Blue Cross Blue Shield, I think talking about freezing wages and stuff like that, and telling that whole story is a very important part. Maybe the AMA, that's a pretty important part as well. And so yeah, it's been slowly meddled with more and more over all that time, and then Medicare just exploded. Total explosion. And then once they created all those problems, they exploded even further with Obamacare. And so now we're dealing with a not market system whatsoever in healthcare. And that, yes, needs to be fixed. It's a difficult sell, but it's the only one that would actually solve the problem if that's what people want to do. I don't think they, I think Bernie wants to do that.
Medicare for All would solve some of these problems in the short term.
It would look great for a minute.
It would look great for a little bit. And then all of the problems that we had prior to would exist and then be exacerbated like 1,000-fold.
Mm-hmm.
I believe they were going to do this in California. Weren't they going to have in California like a California for all?
Well, they got Medi-Cal.
And I'm talking about full blown.
Like everyone.
And then they realized, this is going to be too expensive.
And so what a disaster this whole thing would be.
So it didn't pass.
Yeah. Oh, that whole tangent started with, this is going to equal people paying us having to chip in trillions of dollars extra in taxes every year to a government that's already negative $2 trillion every year. And having a little bit tougher time as every day goes on, getting other people to buy our bonds and keep floating this debt for us, which is how you keep the whole thing going. All right. And then we're going to add on either that much more debt every single year, or you're going to add on what's going to have to be collected in taxes. You're going to have to assume that this government will be able to collect the highest amount of the GDP that it's ever been able to collect, because it's already collecting with 17% of GDP, something like that right now, and that's about the average. That's pretty much what it sticks at. It's going to have to collect 25% of GDP to pay for this.
You're not taking into account the rich people paying their fair share, finally.
Yeah, the rich people are going to pay for it, yeah. That's what it's
they're going to pay their fair share.
Yeah.
Mm-hmm. And of that fair share bucket, we can afford all of this.
We do all of it.
In fact, after we get Medicare for all, I say homes for all.
Just for everyone.
And cars for all, Netflix for all, Wi-Fi for all, Starlink for all.
Think of the lives saved.
Yeah. Think of the opportunities and how productive people are going to be when you're not.
Because they'll have to be, because you're going to be taking 98% of their income to pay for all of it. Okay.
All right. I think that's enough for today.